I'm Dr. Mohan Das. I'm the head of neurology at KIMS over the last 12, 13 years since it has been initiated. Formerly, I was associated with NIMS. I was the head of neurology and dean of the faculty at the institution. One of my main interests has been neuroimmunology, which deals with our defense mechanism as far as nervous system is concerned. And one of the commonest disease affecting this part of nervous system, that means immunologically, is what we call as multiple sclerosis. Of course, multiple sclerosis is a disease which usually affects the nerve sheath, which we call as myelin, which is actually provides the insulation for the nerve. It gets damaged due to possibly some immune-mediated mechanisms. And when this damage occurs, it doesn't occur almost on a continuum. It tends to occur in patches episodically, and so it tends to occur in what we call as relapsing remitting multiple sclerosis. That means an attack will happen, it will affect any part of the nervous system like your vision, your ability to move, or paralyze the hand, or even speech may be affected sometimes. But you may also have double vision or unsteadiness of gait or inability to walk at all because both lower limbs may be paralyzed. Or more commonly, it may be associated with loss of vision, either in one eye or rarely in both eyes. And these sort of changes can occur at any given point of time and occur with abruptly over a very short period of time and disable you remarkably. Now, this usually affects women more often than men, and younger people, that means ages between say 20 and 50 are more commonly affected, more often between 20 and 40. You do see this in children also, and also in the age of say 15 years or so, where it can be a very, very big ordeal for patients to handle this over the years, because this is a disease, once it usually occurs once, it tends to occur again, making you more and more disable and persist throughout life. And till about 1995, there were hardly any treatment modalities available for this condition. But in the last few years, a lot of changes have occurred, both in making a diagnosis as well as to treat these patients. So for making a diagnosis, one of the most valuable tools which turned out to be for diagnosing multiple sclerosis, which looks at the white matter, so-called insulation in the brain. This thing can be very well identified in MRI, and MRI gives you a fairly good picture of how your patient is being affected, how much is the improvement with the medicine, and you can even prognosticate how this patient is going to be with the medicine as it's available tomorrow. As I said earlier, treatment was predominantly directed towards a single attack. When suppose somebody had loss of vision or a weakness, we used to give steroids, which would at least get over some amount of benefit for that patient. Patient who was absolutely not able to walk would walk tomorrow, especially after 5 days of treatment. But this problem was that these attacks would occur again and again, and we had to find strategies to prevent this problem. And the medications initially available were what we call as interferons. This got introduced in about 1995, and they are now almost 21, 22 years into the existence and have possibly saved a lot of patients with multiple sclerosis developing disabilities over a period of time. But that was not 100%. In spite of those medications, a lot of people still had the disease coming back in spite of those treatments, so they had to find more potentially effective treatments. And these, some of them were very powerful, but they had their own side effects. Like, for example, there is a drug called Tysabri, which is actually a monoclonal antibody, which is very powerful. It is actually gives you freedom from disease, which was never heard of in multiple sclerosis earlier. It's been heard in the last few years that you can be either what is called freedom from disease burden or no evidence of disease activity at all. The first time when this drug was introduced, that is called Tysabri, the people felt entirely normal. The disease was pushed back. But this came with its own problem of producing certain side effects, and especially one chronic infection or an infection of a viral infection type, which would produce fatal disease. It's also called progressive multifocal leukoencephalopathy. So obviously, this was not the ideal treatment. If we could manage patients without this, then it would have been much better. And additionally, patients had a lot of problems with using injectables in the form of treatment with interferons. Now, in the last few years, the oral drugs have come to the fore. There are 3 drugs which are now available for oral use. They are called as fingolimod or as tecfidera or abagium, which is also called terfluridine. And these drugs have shown to be equally effective as the injections or a little more effective and have much more compliance because they are much more easy to take. They are also possibly have lesser side effects, but they do still, since they interact with the immune system, do have some amount of side effects off and on. But I think patients are significantly benefited in preventing further attacks and progression of the disease. Now, in addition, there have been few more very powerful drugs which have come, which they say if you use for about 1 year, that means you use this drug called elemtuzumab, which you can use today and use it again after 1 year, and for life the disease may remain completely quiescent and may not affect others. But this is awaited, the more trials are awaited, but I think the drug is showing excellent results. So at the moment, the major aim is to identify this disease very early, in which, as I already told you earlier, MRI is very useful, but of course a clinical suspicion is very much required. And once you identify the disease, if you treat as early as possible to prevent progression and so that this patient can live almost their entire life without being dependent on somebody else.